Now I want to talk a little bit, just sort of on a 30,000-foot view of what our laboratory does. We try to focus on triple-negative breast cancer of all breast cancer subtypes. And so triple-negative breast cancer defines those breast cancers that don't have what we call hormone receptors, which are the estrogen receptor or progesterone receptor. And they're also those breast cancers without substantial expression of what's called HER2, which is the target of Herceptin, trastuzumab, as well as a number of different drugs that have come down the pipeline in the last 10 to 15 years. So really you can see from this little Venn diagram on the right side of the slide that triple-negative breast cancer is a small proportion, but it's also really the worst outcome of all of the clinically recognized subtypes. So it tends to impact younger patients. It tends to have a very aggressive course, and there's really no targeted agents approved, and unfortunately because of that it's currently only treated with chemotherapy. Our laboratory really focuses on two very basic but important questions. So number one, how do we identify patients that will benefit from treatments, and how do we identify them using a precision medicine strategy? So what this means is that if you have all the patients that maybe are triple negative, and there's a new therapy coming down the road, and we know that therapy is effective in maybe 20 to 30% of the patients with triple-negative breast cancer. We want to know, how do we pick those patients out up front? There's two things that really guide this. That's the cost of success and the cost of failure. And so if you think about not only the cost of success goes way down when you're able to pick the right patients who will benefit for a treatment, but the cost of failure also goes down when we use this strategy, which means that the patients that are put on a therapy that they ultimately don't benefit from can be stratified or changed over, triaged to a different therapy that maybe they're more likely to benefit from. So that's sort of the first question, is trying to identify which patients up front will respond to a certain therapy. But number two, and I think, to me, that both of these are important questions, but this is the one that really sort of excites me, especially in the context of the types of therapy that I'll be talking about in a few minutes. This question is, how do we make more patients respond? So we have a really great therapy that comes down the pipeline. It's being tested in clinical trials, and maybe we only have 10% of patients that are responding to a certain drug, but those responses that they're having are really amazing responses. Well, that's very exciting, so we want to figure out how to make more patients have those kind of responses. And the type of drugs that we're studying right now are something called immunotherapy. And immunotherapy is something you might hear about quite a bit in the news as of late because of its successes in a variety of different cancer types, and we're really exploring this, whether these drugs will be effective in breast cancer. And so immunotherapies have had durable responses. And what I mean by durable responses are, these are not your average short-lived, 6-month to a year extension of life in patients. These are cases where patients with metastatic disease are being almost completely cured or have substantially improved survival. We really try to do this by combining drugs. We try to find ways to combine these drugs in order to make more patients respond.